Our next speaker is Dr. Joanne Jeter. She is our medical oncologist for our melanoma team, and she also is a geneticist. So Dr. Jeter, she can give you more information about her.
But I certainly appreciate all of you guys coming out today and joining us and spending part of your Saturday with us to learn about melanoma. I definitely would agree with what Dr. Binzel said in that there is a lot going on right now, and even from year to year, things are changing rapidly. And today, what I'll be talking about is what we call adjuvant therapy for melanoma. And what this really means is, therapy that's given after definitive therapy. So the definitive therapy for most localized melanoma is surgery. But sometimes patients will need to come to, is it not working? Oh, it's not on. Can you hear me now? Apparently I'm not very good technologically. In any case, I was just saying that it's very appropriate that I'm following surgery in our discussions today, because with adjuvant systemic therapy, as a medical oncologist, oftentimes as a patient, you'll start seeing us as a medical oncologist after you see the surgeon for therapy after the surgery. So just to give kind of a quick overview of what the talk will be here today, I want to just talk a little bit about what the definition is of adjuvant therapy and some related terms, and when it's actually given, because it's not something that's right for everybody. Then I'll talk a little bit more about the specifics in terms of what the options are for adjuvant therapy. And again, this is a rapidly moving target right now, and you'll see exactly what I mean. There are different options, and even more options than there were really a year or two ago in terms of the categories of immunotherapy and targeted therapies. And then what are the new directions for adjuvant and neoadjuvant therapy? And I'll talk in just a minute about what neoadjuvant therapy is. So just to define some of our terms here, what is adjuvant therapy? It's basically treatment that's given after the primary therapy to increase its efficacy. The primary therapy for most individuals with melanoma that is not widespread in the body is going to be surgery. I like to tell my patients that in many cases, the best tool we have against melanoma is the knife. And so, of course, we work closely with our surgical colleagues about this. So for stages 0 to 3 melanoma, surgery is considered the primary therapy. And as Dr. Binzel mentioned before, stage 0 to 3 melanoma generally is going to mean melanoma that's confined to the skin, or the regional lymph nodes, the lymph nodes that drain that part of the skin. However, particularly for those who are stage 3 and have lymph node involvement or more extensive disease, radiation, or what I usually try to call systemic therapy may be given in some situations as adjuvant therapy. Now, when I say systemic therapy, a lot of people in that situation would say chemotherapy. But the fact of the matter is, now some of the systemic therapies we're giving are chemotherapy in a classic sense, and some of them are immunotherapy. And I'll talk more about that in a few minutes too. So then a related term, but important as well, and starting to increase importance, is called neoadjuvant therapy. And that's actually a treatment that's given prior to the primary therapy, and it increases its efficacy or it decreases its side effects. Now, this has not been a tool that an approach we've really been taking in melanoma for many, many years. Most of the time we want to get people to surgery as quickly as possible, and that's because in the past some of our systemic therapies were not that effective. But again, with newer effective therapies, like I said, we'll be talking about in a minute, this is starting to be an area that's being investigated more and may change the face of how we treat melanoma. It's important too because, again, sometimes, as Dr. Binzel was saying, you may be in a situation where the disease is too extensive to be removed all in one surgical procedure, or at least in a surgical procedure that's not making Swiss cheese of your leg or what have you. And so in that situation, sometimes the surgeons will come to us and say, look, we really need to try to shrink this down. Maybe if we can shrink it down, we'll be able to go to surgery later. And then it's a much more tolerable surgery for the patient. I'm not a radiation oncologist, but I do want, because this is an adjuvant therapy talk, I do want to just have a brief mention of radiation therapy. As Dr. Binzel mentioned earlier, radiation is classically a tool that we use in fairly limited situations in melanoma. There's some very specific situations, but we do sometimes use radiation after surgery. This can happen if we have, for example, multiple lymph nodes that are involved with the melanoma. In particular, if there's involvement of the parotid gland, which is one of your salivary glands, is kind of right here, because that can be an area that, again, can be very it can be very difficult to resect completely. Also, if there's more than 2 lymph nodes involved in the neck or in the axilla under the arm, radiation can be considered in that situation. Or if there's more than 3 lymph nodes in the groin area, again, we can sometimes consider radiation in that situation as well. But we do have to be careful because just as surgery can cause lymphedema, sometimes radiation can increase that risk of lymphedema as well. So particularly when you're looking at the area under the arm or the groin, we do have to keep in mind that some of the potential side effects may be increased swelling in the limb that area drains. Sometimes there can be what we call extranodal spread. And what that means is when you go to surgery and you have the sentinel lymph node or additional lymph nodes removed by the surgeon, sometimes there can actually be evidence of the melanoma that extends outside of the lymph node itself. And so that means that's another marker that the melanoma might be getting away from our control a little bit, and that we might have to take some extra measures in order to bring it back under control with radiation. Also, if there are large involved lymph nodes, for example, if someone has a lymph node in the neck that's more than 3 centimeters, if you think about, we usually think about inches rather than centimeters many times in the United States, but an inch is about 2.5 centimeters. And so part of this can be, if there is a large involvement of a lymph node, then that could be an indicator that perhaps there's more disease that might be there microscopically, but the surgeon couldn't see to remove it. Similarly, if there are lymph nodes that are greater than 4 centimeters in the axilla or the groin, that would also be a time when radiation might be considered. The other thing that we look at is whether or not the melanoma can be resected completely. And Dr. Binzel talked quite a bit about how the surgeons go to great lengths to make sure that you have a margin of normal tissue removed around the melanoma that they can identify. And that's because sometimes we can have melanoma cells that aren't necessarily visible to the naked eye, but can be seen under the microscope there. So they really want to err on the side of removing every bit of the melanoma that they can during the surgery. However, sometimes despite their best efforts, there may still be positive margins, and that means that the edge of the surgical specimen still has melanoma on it. There could be reasons for that. There could be anatomic considerations. Maybe, for example, a melanoma is really close to your eye. Well, you might not have a lot of real estate to get a 2-centimeter margin in that particular situation, and so sometimes it is what it is, and then you have to kind of make up for it with doing a little bit of radiation or something like that afterwards. The other times that we sometimes will think about radiation therapy is if the disease comes back after having previous surgery. So those would be some of the reasons that we might think about radiation. There are some special kinds of situations as well. Now, most commonly, melanoma arises in what we call cutaneous melanomas. They arise in the skin that we can all see. It's in the usual surfaces protecting our body, but there are some more unusual places that melanoma can occur. For example, there can be what we call mucosal melanomas of the head and neck, and that can be inside the nose or inside the head and mouth, inside the mouth and throat sometimes. These can be hard to detect because it's not as if we're routinely looking inside our nose for skin lesions or things like that. And so sometimes those can be hard to treat. And again, anatomic considerations, you may not be able to get a 2-centimeter margin if you're removing something from the inside of the nose. There can also be melanomas in the female gynecologic tract, in the vagina or in the vulva. And then there can be melanomas of the lower gastrointestinal tract in terms of the anus or the rectum. So those are all special considerations too. And because large margins often can't be achieved in those situations, oftentimes radiation is an adjuvant therapy for that as well. It is important, having said all this about radiation therapy, that radiation therapy in the adjuvant setting really can only control the disease at the original site of disease. It does not have an impact on whether or not the disease has spread. And so because of that, radiation therapy generally is not thought to make people live longer, but it can help control the disease better at the site where it occurred. Does that make sense? Okay. So again, the other thing is as our systemic therapies are getting better, radiation therapy is being used less commonly. And we'll talk, like I said, that's going to be kind of the bulk of the talk today. So then when is adjuvant systemic therapy considered? Again, generally in stage 3 melanomas. If you have a melanoma in situ or a stage 1 or 2 melanoma, the rate of cure with a surgical excision is reasonably high for that. And again, we have to weigh the risks and the benefits of having systemic therapy. These groups are felt, at least at this point in time, not to have enough benefit from that kind of treatment to justify the potential risks of having chemotherapy level type drugs. As newer drugs are becoming more tolerable, again, this landscape may change, but this is where it is at the current point in time. So again, stage 3 melanoma is usually defined as having lymph node involved with the melanoma, or what we call satellite or in-transit lesions, meaning that if you drew an imaginary line between where the melanoma occurred on your skin to the draining lymph node basin, say under your arm or in your groin, sometimes there can be lesions on the skin that kind of occur along that imaginary line, as the melanoma is kind of making a progression to your lymph nodes. Sometimes the satellite lesions can be just like a satellite around the Earth. You know, you have the primary lesion in the skin as the Earth, and there sometimes can be, in a circumference around it, there can be other small offshoots of melanoma, shall I say. Sometimes when people have stage 4 melanoma, meaning that the melanoma has spread beyond the skin and beyond the lymph nodes, sometimes it only spreads to a couple sites, and sometimes we can actually control those sites with surgery. And that's not the most common scenario, but if, say, there's only 1 or 2 lung metastases, sometimes we can go to surgery and remove those. And then again, we would think about giving systemic therapy afterwards, because we do know that if the melanoma has spread to the lungs, that means it's gotten in the bloodstream in order to do that, and that there probably still, even with a surgical resection, is going to be melanoma in the body that we can't see right now based on our ability to detect it. So, again, having adjuvant systemic therapy coming in to kind of back clean up there can be very helpful. Again, as I mentioned before, stage 4 with involvement of distant lungs, such as the lungs, brains, liver, or elsewhere. As Dr. Binzel mentioned, Clark's level is not the same as stage. And I don't want to belabor this too much, but it is a very common misconception in the melanoma community that people will come to me with stage 2 or stage 3 disease, and they're like, I'm really worried because I have stage 4 disease. But the reality is they have Clark's level 4 disease. And the difference between that, again, is that the stage is the extent of spread throughout the body. And in order to really stage someone properly, you often need scans such as a CT, an MRI, or a PET scan. The Clark's level is something that's reported on the pathology report. So you can get that from your skin biopsy. And it shows the extent of extension of the melanoma into the skin at the primary site. So really that's just assessing the primary site of the melanoma. Certainly, theoretically, it's possible that you could have a Clark's level 4 lesion and also have stage 4 disease, but the overwhelming majority of the time that's not the case, so it's important to realize that. Now I'm going to be getting a little bit into what are the agents that we give for systemic adjuvant therapy. And I am going to kind of start with where we came from, because I think that helps to put in perspective what an exciting time this really is right now. High-dose interferon is a treatment modality that was discovered back in the 80s, okay? And this has been the historical standard for many decades, quite frankly. They've tried different dosing regimens and things like that. What I usually tell my patients, or what I did tell my patients about high-dose interferon, is that your body makes interferon when you have the flu. And the idea really is that this is, in some ways, one of the first immunotherapies, because it's helping your body in mechanisms that we don't fully understand to fight the melanoma with using the immune system. So it's a non-specific stimulation of the immune system to fight any remaining cancer cells that might be present after the surgery's been done. This is generally given for a year after surgery, and it is not I don't know if there are any individuals who've had interferon in this group, but it's not a regimen for the weak-hearted, shall we say. And what I mean by that is, for the first month, people came in 5 days a week to the infusion center and had high-dose interferon infusions. They did have the weekends off, but they did that 5 days a week for a month, and then they went on to another 11 months of giving themselves subcutaneous injections of interferon, kind of like you would give an insulin shot. So 1 year of therapy. This is a really challenging therapy. Now, the side effects are manageable, but if you think about it, if I'm giving you something that's a high dose of what you have when you have the flu, you're going to have some symptoms that make you feel like you have the flu, you know? And so things can be very common. For example, fatigue, extremely common with this regimen. By that I mean 96% of people on interferon have fatigue. It can be at different levels. Some people it affects a lot more than others, but generally you're going to notice at least that it's not quite business as usual in terms of your daily activities. You can't have fevers associated with it. You can't, I actually have another slide, we'll go into that in a little bit more detail in a second. The question really was, what is the benefit from interferon? And this was something that was hotly debated. There are strong data that show that having the interferon does appear to delay the time for melanoma to come back, usually by about a year. Most people in the melanoma community agree on that, you know, that statistically that is how the data are interpreted. Do people who have adjuvant interferon therapy actually live longer than those who don't in the same situation? The data are conflicting there. And so then it becomes a little bit of a difficult consideration because you do have a drug that in many ways is difficult to tolerate. And although there is some benefit in keeping the melanoma from coming back as soon, you may still not end up living longer having taken the interferon. So some of the adverse effects that I mentioned here, constitutional things like fatigue, fever, anorexia, or not wanting to eat. Weight loss is common, but I do not recommend it as a weight loss regimen. You know, some patients get very excited when they hear they might lose some weight on this, but that's not the kind of weight loss we want. It often can be muscle mass and not fat loss, and so important to realize that. And malaise or just kind of generally not feeling good is another potential side effect. It also can have what we call myelosuppression, which is basically impeding the function of the bone marrow. So the question is, what is the function of the bone marrow? The bone marrow makes your blood cells, and you have several different blood cells that are made in the bone marrow. That includes your white blood cells that help you fight infection, your red blood cells that carry oxygen for you, and your platelets that help your blood to clot. So if your white blood cell goes down, in theory, you would have an increased risk of infection. However, we have to keep in mind that the interferon is part of your immune system as well. So in some ways, we're kind of taking with one hand and giving with the other. Generally speaking, those who were on interferon were not felt to have increased rates of infection compared to those who didn't, because again, we're stimulating the immune system and taking with one hand and giving with the other in terms of the immune system. When your red blood cells counts go down, you're anemic, and then that means that you may feel weak, tired. Sometimes if you have cardiac conditions or things like that, that can lead to chest pain, shortness of breath as well. And then if your platelet count goes down, then you have an increased risk of bleeding. And so again, most of the times these didn't go down to a level that transfusion or things like that were required, but sometimes they did require adjustment of the dosing for this as well. Another potential side effect is that it can have toxicity to your liver. And so again, monitoring of liver numbers with blood work was very, very important on interferon regimens. It can also cause your thyroid gland located in your neck to dysfunction as well, and that to be dysfunctional as well, and that can of course affect things like your energy and sometimes weight and other symptoms as well. And then lastly, and this was always the thing that was a little bit difficult to address when we're talking about this kind of treatment, is that it does appear to have some effects from a neuropsychiatric standpoint. And what I mean by that is sometimes people do have mood changes on it, and sometimes those mood changes could be very severe. Now, are those chemically induced mood changes due to the fact that we're interfering with the physiology, or is it due to maybe, you know, you're in a bad mood because you don't feel good and you realize you have to do this for a year? You know, so I think that those things kind of both come into play, but those are well, you know, those kind of neuropsychiatric side effects are well documented. Doesn't mean they happen to everybody. They happen to everybody, but it is something that we have to keep in mind. And many times doctors who were treating people with interferon would mandate that they start on an antidepressant at the same time. So then now we're going to move into the new era of immunotherapy. And you'll remember that I said that interferon really was started in the 1980s. So some of you may have heard about ipilimumab or Yervoy. This has been a drug that's been approved for some time now in the metastatic setting for people who have stage 4 disease that is not managed surgically. This drug was also approved by the FDA in 2015 for therapy after lymph node dissection therapies for those with stage 3 melanoma. So if you think about it, a lot of time obviously has passed between the 1980s and 2015. The study that was done that led to the approval by the FDA for this was looking at people who had stage 3B, 3C, and 4 melanoma. So stage 3B and 3C are subgroups of melanoma that basically say, how many lymph nodes were involved or how serious or thick was the primary melanoma. But it was in more advanced stage 3 melanomas. It wasn't in extremely early stage 3 melanomas. The reason that that's important is that, when the FDA did its approval, they just said stage 3. They didn't say stage 3B, C, and it's also used in stage 4, I should say, too. But again, they didn't specify the substage within the melanoma group. And many people did end up using it for stage 3A melanomas as well, just as kind of an extrapolation of this principle. There was some very interesting debate in the melanoma community about the dosing of this. The FDA-approved dose for adjuvant therapy was 10 milligrams per kilogram. So this is a weight-based dosing. Depends on how much you weigh, depends on how much you get. The thing that was tricky about this was that when someone has metastatic disease, we usually give 3 milligrams per kilogram of ipilimumab. And so in some ways you kind of question, why would we give such a lower dose in someone who has got less extensive disease and potentially less benefit? And that was something that was always a bit of an inconsistency. But the short answer is the study that looked at 10 milligrams per kilogram was completed first, and that was the study that went to the FDA. Still a little bit of a paradoxical kind of situation there. The side effects were less frequent, but potentially more severe than that with interferon, and I'll talk about that more in a minute as well. But generally speaking, many individuals did tolerate on a day-to-day basis the ipilimumab better than they tolerated interferon. There was a demonstration of significant improvement in survival. And again, there was not a direct comparison to interferon, but compared to placebo. And part of the reason for that was, as I mentioned before, the data on whether or not interferon actually improved survival was conflicting. So it was not clear that that was the standard comparator there. And again, as I mentioned, not directly compared to interferon for that test. So this is kind of a cartoon of the mechanisms of 2 of the immunotherapy drugs that we're using now. And so we'll be looking here at the left side of this cartoon, which is CTLA-4 blockade. Ipilimumab is technically a blocker of the CTLA-4 pathway. And we can see that this is dendritic cell, which is part of the immune system, and this is the helper T cell, which is again another part of the immune system. And basically, the CTLA-4 antibodies affect this interaction here between these 2 elements of the immune system, with the idea that they're stimulating the immune system to fight the cancer. Again, it is important to realize that immunotherapy is not something that acts directly on the cancer, but stimulates your body to fight that cancer. That can have some ramifications to that. It means it may not work as quickly as it might be as a drug that works directly on the cancer, but it also can mean that there can be more sustained results and that immune stimulation can last longer as well. I'll talk about the other half of this slide, which is for the PD-1 inhibitors, a little bit later on in the talk. So now, any kind of systemic therapy, there are going to be the potential for some side effects. And this is looking at potential side effects, not just for ipilimumab, but for the other drugs that we'll talk about in a minute, nivolumab and pembrolizumab. If you think about it, the basic mechanism of this drug is that we're stimulating your immune system to fight the cancer. So the corollary of that is if we're stimulating the immune system, sometimes it gets a little excited and it fights things beyond the cancer. And it can go after some parts of your body that would be considered normal. So you can have autoimmune colitis or inflammation of the bowel. That can lead to diarrhea. That's something that we have to kind of stay on top of because, again, if that goes unchecked, that can actually become a very serious condition and can actually lead to colon perforation. Now, having said that, if it's caught early, it is very treatable. And that's one nice thing about immunotherapies is that we have drugs that put brakes on the immune system. They're called steroids. And so these side effects can be treated very effectively with the use of steroids. There also can be autoimmune dermatitis or rashes that are caused by the immune system being stimulated, autoimmune hepatitis or inflammation of the liver, and again we monitor that through blood work. Autoimmune hypophysitis, which I have to be honest with you is a word that I didn't really know until I started using immunotherapy. That's inflammation of part of your brain called the pituitary gland. And that is kind of your master gland that controls a lot of your hormone levels. So if that gets out of whack, your hormones can then get out of whack, and that can lead to a number of different problems, some of which can sometimes be life-threatening. So again, we do have to, this doesn't happen often, but it is something that we do have to monitor and be aware of in patients who are on these kinds of treatments. I've listed here some of the hormones that can be affected with hypophysitis. There can be neurologic side effects as well, and so there can be inflammation of the nerves that are associated with immunotherapies as well. There can be autoimmune inflammation of the kidneys or autoimmune inflammation of the lungs, and so these are all things that we have to look out for. Now, having said this, it's always scary to see a list of potential side effects, but that doesn't mean that this happens to everyone. One of the drugs that I'll talk about in just a minute that is an immunotherapy is Keytruda, or the drug that Jimmy Carter got for his melanoma. Now, he did not get it in an adjuvant setting. He got it for stage 4 melanoma, but he was 90 years young, and he was able to tolerate that. And so this is a drug these are drugs that can be tolerated in even in older population, and you can't say that for all systemic treatments, so very important to realize. Certainly I have had in my practice, and I know my colleagues have as well, people who are in their 80s and 90s who have taken these drugs and been able to tolerate them without significant problems. So there are some unique considerations for immunotherapy. As I mentioned before, the onset of action can be delayed, and if you think about it, that's because it's not directly working against the cancer. Sometimes you may actually see the disease, particularly in the metastatic setting, where these were initially approved, you may see the disease get a little bit worse before it gets better. And that was one of the things we kind of had to learn about for these drugs, is that we can't, it's kind of like, what is it, you know, you smush a bug with a rock and you want to lift up the rock and kind of see what's under it. You can't lift up the rock too soon, okay, because sometimes that'll keep you from continuing a therapy that has the potential to have a little effect if you just are patient and wait it out a little bit longer. And this principle actually led to new criteria to assess response to autoimmune therapies. And I'm not going to go into the details of that today because it's really beyond the scope of what we're talking about. But again, looking at a little bit differently than how we do for chemotherapy in terms of the shrinkage of tumors on scans, the presence of new disease, et cetera, et cetera. As I mentioned before, although the side effects, there is a side effect profile, we do have effective, if you will, antidotes for those side effects in terms of steroids. And then I'm going to go on now to the next class of immunotherapies, and the one that has gotten a lot of press recently is called nivolumab or Opdivo. You actually may have seen commercials about this on television. It's been approved in a lot of different diseases, but melanoma was the first, so important to realize that as well, but also in lung cancer and many, many other areas of types of cancer as well. It was initially, like ipilimumab, approved for metastatic disease, but in December last year, it was approved for individuals with stage 3 melanoma after surgery had been completed. So like I said, you know, we had nothing really in the way of major changes over many decades, and now things are really accelerating just in the last few years. The name of that study was called Checkmate 238, and it did show improvement in recurrence-free survival compared to ipilimumab. So it was compared to, it had a modern comparator, did not compare to placebo or to interferon. And the study again includes stage 3B, 3C, and 4 melanoma, but not stage 3A melanomas. The way that this is given is that this is an infusion that was given every 2 weeks for 1 year. Now again, this immunotherapy landscape is moving quickly, and so we now actually have options of giving a higher dose on a monthly basis. And as you might imagine, when you're coming back and forth to the cancer center for infusions for a year, it makes a big difference if you're coming every 2 weeks versus coming every month. So that's something that again is that was just as of March, I believe, of this year. A similar drug is called pembrolizumab or Keytruda, and again, this is the drug that Jimmy Carter had, as I mentioned before. It has not yet been approved at this point in time by the FDA for stage 3 disease. It is approved for stage 4 disease. And some of you in the room may have actually participated in one of the clinical trials looking at Keytruda in this setting, which was the S1404 study. This looked at pembrolizumab versus interferon or ipilimumab for people who had resected stage 3 melanomas. And again, the results of that study have not been finalized yet, although I anticipate that they will be. It's hard to say, probably in the next 2 years at max. And again, not FDA approved for this indication at this time, but it is approved in stage 4 disease. So again, looking at the mechanism of the PD-1 inhibitors, we're looking at the right side of the screen, and we can see that, again, the T cells are involved in this process, but they're interacting directly with the tumor cells. And so this has, a couple of implications. We have found, generally speaking, in the metastatic setting, as well as the study that I just mentioned, that the PD-1 drugs tend to be a little bit more effective than things like ipilimumab, perhaps because they're interacting a little bit more directly with the tumor. There also is a lower potential for side effects. Again, that's not to say that they're free of side effects, and the side effect profiles are very similar, but the incidence tends to be a little bit lower. I'm going to go through this quickly because we are rapidly running out of time here. As I mentioned before, I am a geneticist, and it is important to think about genetics of melanoma. Melanomas are not all the same. They can have different genetic profiles based on where they arise, and one of the most common mutations that's present in some melanomas is called BRAF. Usually this is kind of a melanoma that occurs in skin that doesn't have chronic sun damage, usually not a mucosal site, usually not the palms of the hands or the soles of the feet. There is another drug here at the bottom called NRAS, which is a surrogate for MEK. The reason that I mentioned those two is because we have drugs that specifically target cells that have those mutations, and that's the targeted therapy. I am going to skip this in the interest of time, but this is kind of a cartoon of the pathway here, and you can see where the BRAF inhibitors work at one point in the pathway, and then the MEK inhibitors work a little bit further down on that same pathway. So this is extremely new information. The BRAF and MEK inhibitors were studied in the adjuvant setting in a study called COMBI-AD. And this did show, again, an improvement in recurrence-free survival and suggested an effect in overall survival for the combination of drugs Dabrafenib and trametinib compared to placebo in this setting. This study, unlike the others, did include stage 3A melanomas as well as 3B and 3C. And this is an oral treatment, 2 drugs that you take by mouth for 12 months. So again, in many ways, a little bit easier than having to go for infusion multiple times. And this combination was just approved by the FDA for adjuvant therapy on May 1st. So this is a brand new option that we have that we can now offer to our patients. So I'm very excited about that. There are other BRAF inhibitors and MEK inhibitors, and likely those approvals will probably be forthcoming as well. There are a couple of caveats to this. As I mentioned before, not all melanomas have BRAF mutations. We need to know before we start these drugs whether or not your tumor has a BRAF mutation, because if it doesn't, then it's not going to be effective, and you will still have the potential for side effects. Sometimes having that tumor testing can delay treatment a little bit because sometimes it can take up to 3 weeks to get that result. So I think some of the mechanism of how we're going to be able to do this practically, is something that we're going to have to probably look into a little bit further. So again, not an option for every melanoma, but a very exciting new option that we have. There are some side effects associated with BRAF inhibitors, but they are tolerated very well. Just very briefly, they can paradoxically increase the risk of squamous cell carcinomas, which are a less deadly type of skin cancer. These can generally be managed simply by surgery, a much smaller surgery than the surgeries that Dr. Binzel was describing. There can be some light sensitivity of the skin. There can be some aches and pains in the muscles and joints, fatigue, and we do also have to monitor the EKG tracing because there can be what we call prolongation of the QT interval, and I'm not going to get into that today in the interest of time. This talks a little bit about, again, other drugs in looking at the secondary skin cancers. And I'm not going to really go into this in the interest of time, but just to say the addition of the MEK inhibitor to the BRAF inhibitor has been shown not only to increase the effectiveness against the melanoma, but also has been shown to decrease the rate of having those second squamous cell carcinomas of the skin as well. This is, again, a cartoon of that, but I know we're running quite long here. The other things that we do have to think about with the combination of these 2 drugs is monitoring for cardiac toxicity. We do have to do tests to see how the heart squeezes and if it's squeezing properly and monitor that. We do have to literally keep an eye on the eyes because sometimes there can be some changes to the eyes. And this drug can also prompt fever. Having said that, though, again, this regimen tends to be very well tolerated as well. Ocular melanoma, I like to at least put something in here, but the short answer, unfortunately, is we don't have answers in adjuvant therapy for ocular melanoma right now. It is a different disease. It doesn't have those same genetic changes, and we're still in the process of learning what's best in this situation. We did have a clinical trial open that has closed recently looking at this question, and we'll be eagerly awaiting those results. Briefly, again, what happens after adjuvant therapy? Again, usually adjuvant therapy takes about a year, but then we observe for recurrence of the disease, which can occur in the skin, can occur in the lymph nodes, or can occur at distant sites. And usually the dermatologist, the medical oncologist, and surgical oncologist are working together to monitor you for that. And again, as Dr. Binzel mentioned, we also have to keep our eye out for separate primary melanomas, and our dermatology colleagues help us a lot with that. As there are new answers, there are new questions as well. We don't have a direct comparison between targeted therapies and immunotherapy in the adjuvant setting. And so that's something that's going to be a question that needs to be answered for those who do have BRAF mutated melanomas. In the metastatic setting, we're using the combination of ipilimumab and nivolumab. Is that something that would be appropriate for people if they are resected and surgically free of disease? We don't know that answer yet either. Could these new systemic therapies have an effect on the extent or types of surgeries that are done? Again, an open question. Are there markers who will tell us who requires adjuvant therapy or who will respond to it? Again, a question that's been around and still very difficult to get the right answer for that. And then, do we need to start thinking about this in stage 2 disease? Is there a role for adjuvant therapy in melanomas that do not have lymph node involvement? Now that these treatment regimens are a lot more tolerable, the answer might be yes. We don't know yet, though. So, this is just a cartoon of the clinical trials that we have currently at OSU. And what I've been talking about really, if you can see here, is just somewhat the tip of the iceberg. We think about melanoma, whether it's resectable or unresectable. And then before surgery, we can think about sometimes giving treatment for a specific kind of melanoma called desmoplastic before surgery. There is also a study of a vaccine that has been a consideration as well. And again, due to time constraints, we can't really talk about that in detail. But that's something that certainly is an exciting new area of investigation. So I'd like to thank you for your attention, and thank you to all the study participants who are helping us find these answers, because we're moving forward, and it's really very moving, actually.
Thank you. Unfortunately, due to time constraints, with Dr. Jeter stay